And welcome to this new section called Key Blood Tests, Biomarkers, and Longevity. I'm Dr. James Machino, and I'm happy to present this to you. This course, if you've been with me so far on this platform and you've seen the previous courses that have led up to this one, then you'll see that much of what we're going to see in this program is a review of many of the blood and lab tests we've seen so far and sort of putting it all together into a comprehensive assessment, the way that you would do when there's a patient in your office and you get in their blood work and their urinalysis report is given to you, sort of a snapshot of looking at everything and see how all these pieces fit together into a profile. And so without further ado, let's get started. The purpose of this subject for our purposes is that many medical doctors often don't do a complete workup in many cases, meaning that they sometimes don't order all the blood tests that you and I would think would be important. So you want to see what's been done so far, and then if there's something missing that you think is important, whether it's homocysteine or red blood cell folate or fibrinogen or creatinine, serum ferritin, you might want to then point it out to the patient, see if they can get that done. And sometimes doctors miss things that turn out to be quite important. I've seen situations where the person's year after year has a very high serum ferritin level, and they have no other indication of inflammation, autoimmune disease, or an acute phase, infection. And in a situation like that, the high ferritin should be examined to see if the person has the genetic marker for hemochromatosis. Because if it's left unchecked and they have hemochromatosis and it's left unchecked, then that iron can build up in the liver and eventually cause liver failure. People die from liver failure due to hemochromatosis, sometimes because the person never undergoes the genetic test that would determine that they have it. And if they do have it, the treatment's very straightforward. They do some bloodletting periodically to keep the iron lower, and the person's fine. So it's important that you look at the lab tests that have been done. Don't just assume because someone else has looked at it, even if they're an expert, that they may not have missed anything, or that some tests that should be done, you want to point out that maybe this would be the next step based on your exam. Also, certain blood tests are early harbingers of escalating risk of premature death and common morbidity issues that are often ignored by medical practitioners, just the way that they look at things. In other words, what I'm saying is that sometimes the ideal blood value of a particular test, let's say it's total cholesterol or LDL cholesterol, that the ideal level for longevity might be different than what is considered to be the medically accepted range in that situation. So the way you and I would look at the lab work would say this person's cholesterol is a bit elevated and we should be taking some steps to bring it down. Whereas in the medical guidelines, it's like, well, if the cholesterol is a little bit high, I'm not too worried about it because the other risk factors are keeping the person's 10-year risk of having a heart attack below 10%, so I don't need to do anything. But that's not necessarily the best practice for longevity and healthy life expectancy. Looking at the patient's blood work and providing intelligent, evidence-based feedback, I will tell you, it really earns you the respect from the patient or the client, and it really will improve then going forward better compliance with the recommendations that you make around nutritional medicine, because then you can take that lab report and with a red pen you can circle the things that you don't like. The person, these are the numbers that I'm seeing, and then you write down the numbers that you would like to hit and say these are the goals for us, and here's how we're going to get there, and we're going to monitor your blood work every 3 to 6 months. And we need to get these numbers here. This is what's safe. This is the level of blood value for this test that is associated with longevity and most disease-free existence. Is that what you want to have? Yes. Okay. So here's the number. So having tangible numbers in front of the patient or the client really improves their compliance. So this is knowledge that every holistic health practitioner should be aware of. If optimizing a person's health and longevity potential for all your patients and clients is one of your core objectives, and I think it should be. And remember that most people over the age of 40 are already on the downward spiral towards some kind of morbidity or mortality or something that will catch up with them in terms of shortening their mortality. And you are really becoming a super highly qualified individual that can put nutrition and lifestyle practices in place for that person to reverse some of that downward spiral, reverse some age-related changes, and reduce their risk factors and help optimize their genetic potential. Drugs alone can't do that. This requires a proactive, evidence-based lifestyle approach with having all the respect in the world for what drugs can do. But this is the part that's missing in the management of patients in the modern era. So the topics that we're going to cover, we're going to review and put all the pieces together for a cardiovascular risk assessment, because cardiovascular disease accounts for, well over 40% of all deaths each year. After cancer is the second leading cause of death, and it's really, cancer and cardiovascular disease are really neck and neck right there. And, we have ideas as to how to reduce risk of cancer, but we really know the risk factors for cardiovascular disease. They're real tangible things that we can see and measure, and we know how lifestyle can help to reverse those risk factors. So we're going to come back and revisit that. And then other blood work interpretation, where I'll look at red blood cells, anemia and related disorders, and then white blood cells, infection, inflammatory and related disorders, common liver function tests. We've seen them before, we're going to see them again. Inflammatory markers related to diagnostic blood tests, kidney function tests, again, we'll see them and we'll tie all these pieces together. Some other standard blood tests and we'll review that we've seen before, we'll sort of incorporate all of this. Then we'll look at ideal levels of certain vitamins and minerals on the blood panel. And also we'll look at hormones and endocrine assessment, which we really haven't seen yet. So we'll touch on all of these and we'll put it together into a sort of a comprehensive picture. So a few initial considerations to explain the mysteries of longevity, because we all know someone, or we have a person who told us, my great-great-grandmother, or my mother, or my granddad smoked cigars every day, 2 packs of cigarettes, drank whiskey, had, big chunks of butter and lard every day, lived to be 110. There's a lot of stories like that. But, these people are the outliers. The reason that insurance companies reward people now for having good wellness behaviors, staying at their ideal weight, not smoking, and so on, because the probability of you having a healthy life expectancy that's really, gives you the best bang for the buck. It really starts to factor against you when you have certain lifestyle practices in place, like drinking excess alcohol and smoking cigarettes and being obese and not doing exercise, all these things that we know about. But there are some outliers, and you say, how can you explain this? Well, it's explained by the fact that some people inherit, and not that many people, but these outliers, they inherit these unbelievable genes. Genes that can repair DNA damage like nobody's business. So not everybody who smokes cigarettes gets lung cancer or a cancer related to smoking. And so the people who don't get lung cancer or smoking-related cancer, very often it's because they just have great DNA repair enzymes that as the damage gets done, as the mutations are occurring, they have enzymes that go out and will fix the mistakes so that you don't have these mutations that lead to cancerous change. And in terms of cardiovascular disease, the people having butter and lard and fried foods and being obese and all of this, not exercising, very often they just have great genes where they just make LDL receptors so well, they're just clearing that cholesterol from their bloodstream extremely well. They eat all these horrible foods and their cholesterol doesn't really go up that high. Or they have great genes where they have tumor suppressor genes. So the tumor suppressor genes are like the surveillance system inside the DNA. And when genes are breaking or there's mutations starting to form, the tumor suppressor genes can actually identify that there's a problem there and send their little DNA repair enzymes out in time to fix the mistake before it becomes permanent. So you protect those proto-oncogenes before they can actually become oncogenes and create cancer. Well, let's look at a few examples. So in nature, we have some examples of this. The Deinococcus radiodurans bacteria. It can survive the coldest cold. It can survive radiation exposure, dehydration, being put in a vacuum, acidic environments. It's therefore known as a polyextremophile. and has been named the world's toughest bacterium. So, how does it accomplish all this? It does it by having incredible DNA repair enzymes. So you damage that cell, but the DNA repair enzymes are so amazing, they will repair the damage and the bacteria comes back. So in nature, we have examples of this, and I think there's some human polyextremophiles. So here's Keith Richards, who we know and love from the Rolling Stones, who's smoking, drinking, he's done all kinds of drugs. If you read his book, his autobiography, and he's been in rehab many times. He's come through all of this, 74 years old in 2018, still going strong as of this recording. And you say, how does someone like this, not get cancer or die of something, get dementia? I mean, just must have incredible DNA repair enzymes. So when we look at the common traits of people who have this sort of functional longevity characteristics, in addition to great genes, they're often people who, for the most part, are very skinny. Rarely does someone who's really obese they might live into their 80s, but usually their functional life is tremendously compromised. Dementia, Alzheimer's disease, crippling arthritis, they can't really move that well, gangrene and amputations. I mean, they might get there, but in terms of people who sort of remain functional, usually they're very skinny. People like George Burns, who smoked until he was over 100 years old, and Keith Richards and Mick Jagger, these guys who are, getting up there in age, and they're thin. And that's one of the keys to, living long and also being functional, unless your bones collapse due to osteoporosis. And they practice systemic undereating, right? So that's just, when you eat a little bit less, like 10% less than what your body normally would need, there's less metabolic stress on your body. So that's different than staying thin or at your ideal body weight by exercising and then eating to gain lean mass, things that I normally do. I try to keep my body fat down around 12%, but I eat a lot of food because I'm exercising really hard. Well, that, according to longevity research, doesn't really work that much in your favor. You're better off to practice systemic undereating, even if it means that you're moving your body a little bit less. And of course, having great DNA repair enzymes, having really good functional tumor suppressor genes, having fabulous LDL receptor mechanisms so cholesterol doesn't build up, and not being depressed, like mental health factors into longevity as well. Having some optimism and not being in a depressed state or super stressed out state where your cortisol levels are sky high. These are some of the common traits that have been identified. But the blood work and other biomarkers of longevity and disease risk that we're going to see, we're going to be looking at blood work because it provides objective assessment of disease risk, disease presence, and disease monitoring, and thus it helps to fine-tune the lifestyle recommendations that you make, because you can then monitor the blood work to see if your recommendations and the patient's compliance are actually having a change that's measurable. So it's not just theory and just some based on what you believe to be a good idea for someone. The idea is to have, where you can, tangible measurements of progress in the person's health status. So having said that, let's get started. So part A of this program is a review of the cardiovascular risk analysis and other courses. Essentials of Nutrition and Metabolism, Part 1, in the cardiovascular disease section, and then a little bit again in the course on Essentials of Pharmacology. We've touched on this before, so I can go through it fairly quickly. I just want to show you how all the pieces come together into a profile. Because in every patient, you should really, because cardiovascular disease is, the second leading cause of death, you should do a cardiovascular risk assessment on every patient that you see, every client that you see, just to give them some feedback on that, regardless of what their chief complaint is. That's my view. So remember, these are stats from the UK, but it's similar in North America. And that is that these are deaths each year from coronary artery disease, accounting for 26% heart attacks and so on. Here's stroke, and here's other cardiovascular disease deaths. So well over 40%, maybe up to 43% of all deaths in men each year are from cardiovascular disease, and roughly the same in women. Remember, in Canada, women over 50, the leading cause of death in women over the age of 50 is cardiovascular disease. Everyone worries about breast cancer and colon cancer, and they're all really valid. But cardiovascular disease is the leading cause of death even in women after menopause. So it's not just a male health condition. So let's put the pieces together. So here's the practitioner cardiovascular screening form that I put together, that I use. And I will give you copies of this in your course notes so you can implement this into your own patient intake. So they have the patient's name, the assessment date, their gender, their age. Remember, as you get older, the older you are, the greater the risk for cardiovascular disease. For men beginning at age 45 and for women beginning at age 55, your cardiovascular disease increases progressively and dramatically as you get older. You want to know their systolic blood pressure. You want it to be 130 or less, more ideally under 120. Their diastolic blood pressure, you want it to be 80 or less, more ideally 70. And their resting pulse rate. If they have more cardiovascular fitness, then their resting pulse rate should be down, 58, 62, maybe even lower than that. If they have a resting heart rate of 85, it's like, wow, either you have some tachycardia, or your body's ability to extract oxygen from the bloodstream is not that good, so your heart has to pump more frequently, so your cardiorespiratory fitness is not so hot. And then, are they a diabetic? Yes or no? With diabetes comes a greater risk of cardiovascular disease. You might want to make a comment there. Well, they're not a diabetic, but they're a pre-diabetic, and they're watching their blood sugar. Are they a smoker? Yes or no? And if so, how many cigarettes a day? For how many years have they been smoking? Was it they have one cigarette a day, and they, just 3 times a week, or is it, 2 packs a day? For total cholesterol, the ideal level that we shoot for is 3.9 millimoles per liter or lower. And this just shows you, I included here how to convert from millimoles per liter to milligrams per deciliter. I did that for some of these main blood tests. And remember that some people will say, if your cholesterol goes too low, it's bad for your brain. Your brain makes its own cholesterol. It's not dependent on your blood cholesterol. The brain makes its own cholesterol based on its own needs. So don't worry about having a cholesterol that's below 3.9. That's how you reduce your risk of having a heart attack. In an LDL cholesterol, I'd like to see it, below 1.8, certainly below 2.0. Certainly in high-risk patients like diabetics, it needs to be 1.8 or less. And then the HDL cholesterol for men above 1.17, for women above 1.42. Remember, that's the good cholesterol that does reverse cholesterol transport. And the total cholesterol to HDL ratio should be 3-to-1 or lower. I'd like to see it under 3-to-1 personally. And then fasting glucose, if blood sugar goes up, there's more inflammation in the blood vessel wall, there's more glycosylated proteins, and hemoglobin A1C is rising. This produces inflammation and little crystals, also increasing risk of kidney disease. So I don't like to see a fasting glucose that's above 90 milligrams per deciliter or 5 millimoles per liter. In fact, I like to see this number under 4.7. Remember that fasting level means that the person has fasted for at least 12 hours before the blood work has been done. Fasting triglyceride levels on 1.5 millimoles per liter or less. And C-reactive protein, a marker for inflammation, I'd like to see it well under 2.0. I like to see it under 1.0 actually. And then fibrinogen, a protein made by the liver, that can be converted into fibrin very easily in the presence of thrombin. And that would cause the platelets to clump together. Making your blood excessively sticky increases the risk of thromboembolic disease, which can lead to a heart attack, thromboembolism in the lungs and elsewhere, stroke. So I like to see the fibrinogen level in the ideal range. A lot of doctors don't measure the fibrinogen level. But in women who are on birth control pills or hormone replacement therapy, any previous cardiovascular risk analysis that was positive, fibrinogen should be looked at. The INR, the prothrombin time, the stickiness of the blood, the clotting behavior. The normal range is 0.8 to 1.3, the INR, the International Normalized Ratio. Remember, doctors will sometimes put people on warfarin, Coumadin, and other anticoagulant drugs to make the INR go up a little bit higher. If they want to thin the blood in, mitral valve disease, valve replacement in the heart, or people with atrial fibrillation, it wouldn't be uncommon for a doctor to want to thin the blood in those cases. Their body mass index, which is their weight over their height squared, which is weight is in kilograms and height is in meters. So if you want to an easy way to do the math is you multiply their weight in pounds by 0.45 to get their weight in kilograms, multiply their height in inches by 0.025 to get their height in meters, then multiply that number by itself to get it squared, and then you divide the weight by the height, and you get a body mass index. I like to see the body mass index under 26 or 25, but as soon as you're up higher than 27, you start to see more cases of high blood pressure, much greater risk of diabetes, and dyslipidemia, and increased risk of certain cancers as well. Waist circumference, for men under 36 inches, for women under 33 inches, or the waist should not be more than half the person's height in inches, right? So if a person is 70 inches tall, then their waist circumference shouldn't be any higher than 35. And do they have a personal history of heart disease, stroke, or related cardiovascular disease, or kidney disease, or have they had a vascular procedure, angioplasty, bypass surgery, coronary stent? If so, make some comments on your form, because now it's a higher risk individual, in which case you want to get all those blood markers, all those cholesterol levels and triglyceride levels and glucose levels, fibrinogen levels, right down into the safest possible range. And what's their exercise program, and do you need to modify that for them? And what's the estimated glomerular filtration rate, the EGFR? As soon as it's below 60 milliliters per minute, you're starting to get into some decline in kidney function that you want to keep an eye on that. Doctors get really concerned once the EGFR is below 35. They start sending you off to a nephrologist, or sometimes sooner if there's microalbuminuria, if there's like protein in your urine or red blood cells in your urine, then you're going, or glucose in your urine, you're going sooner to a nephrologist. And the blood creatinine. So every day your body's breaking down a certain amount of muscle protein. Creatinine is an end product of metabolism. It gets cleared by the kidneys, or filtered by the kidneys in a steady state. There's nothing else really competing with it. So if you're not excreting creatinine at a normal level, and it starts rising in your bloodstream, there's kidney dysfunction. The kidneys are not functioning properly, and so it's an indication of kidney disease. It needs to be investigated if your creatinine level is outside of the normal range. And then uric acid, it's a risk factor for cardiovascular disease. NGAB makes platelets really sticky. It impairs endothelial function. So those are the values. Sometimes uric acid is not measured on the blood panel. You should request it. And then there's the albumin to creatinine ratio. Now this is really a urine test that's used in people that have some form of cardiovascular risk or renal failure at some level. But as that level gets higher, then you start to see the person has a greater risk for heart disease and stroke and all-cause mortality. So this is a key indicator that's used in people that have existing cardiovascular disease or some form of kidney disease, chronic kidney disease or acute kidney disease, to actually understand what the risk is of these possible events. And then homocysteine, of course, homocysteine can leak out into the bloodstream if the levels are too high and damage the wall of the artery, make the LDL cholesterol more oxidized, so it gets picked up by the macrophages and into the plaque, and it increases endothelial dysfunction. The platelets get stickier, so you want to have an ideal homocysteine level. The ideal is below 6.3 micromoles per liter. Most doctors will allow you to have a homocysteine level that's 10 or 11 or 12 before it really shows up as an abnormality on their blood work. But I like to see a homocysteine of 6.3 or less according to longevity statistics. And then fructosamine, the sugar coating of proteins in the bloodstream, that normal range is you see 205 to 285. It's an indication of sort of the medium range amount of your glycemic behavior. in your bloodstream. How much are you sugarcoating those proteins in your bloodstream and creating those age proteins, advanced glycolylated end products that produce inflammation and make little tears in the blood vessel wall, form crystals in the kidneys and behind the eyes, and promote blood vessel inflammation and increase risk of cardiovascular disease. Fructosamine is so important that if you go to have key man insurance with a big life insurance policy, $1 million, $2 million or more, most insurance companies insist on seeing your fructosamine level. But most doctors in a routine annual exam don't really look at fructosamine, so you may want to request it. And what's missing here, and I will put it in, of course, is hemoglobin A1C. You want to have a value that's below 5%. Ideally below 4.5, and once you get to 5.5, those numbers are getting into the diabetic range and pre-diabetic range. So a value of under 5 is ideal for the hemoglobin A1C. I will put that into the course notes. And then there's this metabolic syndrome. So there was this update in 2008 looking at metabolic syndrome. If you have 3 or more of the inclusion criteria that you see here: abdominal obesity, high triglycerides, low HDL, high blood pressure, not even high, just sort of just creeping up, fasting glucose in that intermediate zone. This gives you a greater risk for diabetes and increases your cardiovascular risk quite substantially. So this is known as the metabolic syndrome. Make sure that you're really familiar with these inclusion criteria and decide if the person has metabolic syndrome or not based on your exam and the blood work that you're seeing and the person's blood pressure. So then, of course, there's the 10-year heart disease risk score based on the Framingham Heart Study, and we've seen these forms before. I'll review them for you in a second. And then you want to know, are they on any current cardiovascular medications? Statin drugs, fibric acid derivatives, the high niacin. Are they on one of the other, bile acid sequestrant drugs? Are they on high blood pressure medication? So you want to know what cardiovascular medications are on: digitalis, digoxin, blood thinners. You want to include that in your overall analysis for cardiovascular risk. And are they a candidate for other cardiovascular tests? So based on your assessment, should this person be sent for a stress test? They're getting recurrent chest pain, or you just feel they've got so many cardiovascular risk factors, they should go and have a proper stress test done. Chest pain upon exertion, definitely. Shortness of breath, lightheadedness. They're over the age of 60, not accustomed to exercise, and you want to put them on an exercise program. They should really get a proper medical exam with an EKG and the entire workup, and maybe even a stress test as well, in my opinion. If there's been a family history of cardiovascular disease before the age of 60, they need evaluations at a higher level. If they have pectus excavatum, where they have their sternum doesn't come straight down, but rather sort of goes inward, like pigeon chest, as it sometimes is called, that can cause irritation to the heart muscle and create hypertrophy that can lead to abnormal heart function as the person gets older. That may need to be examined with imaging and cardiovascular assessment of ECGs and so on. And if there is a problem there, they can do an ablation type of treatment to help rectify it and get the person functioning better. Have there been previous cardiovascular episodes? Myocardial infarction, a stroke, transient ischemic attack, angina, deep vein thrombosis. Do they have an arrhythmia that's being treated? All these things have to be factored in to determine if you want to refer them off for further testing. So these are other tests they may have had, or you might want to have them discuss with their MD based upon your assessment: a resting ECG, a stress electrocardiogram, an echocardiogram to look at their valves, thallium uptake, angiography, and other tests that are beyond the scope of what you and I can actually recommend. And this, of course, brings us back very quickly to that 10-year risk analysis in cardiovascular disease that doctors use as their guideline from the Framingham Heart Study. So once again, they use a form like this to calculate the person's overall 10-year, what is the person's risk of their risk of having a heart attack over the next 10 years, if it's less than 10%, then they usually don't get too excited. They usually don't act or start even writing drugs or prescription drugs. Once it's over 10%, then they usually get involved. Once it's over 20%, then they start to really get super aggressive. So the way that you determine that, of course, is you look at the person's age. The older they are, the more points score against them. Now we're looking at LDL levels, and the higher your LDL, the more points score against you. Then you look at the HDL, and you look at blood pressure, and you're grabbing the points based on how the person's scoring. Are they a diabetic, yes or no? Are they a smoker, yes or no? And you take those points and put them into the corresponding box for age, LDL, cholesterol, HDL, blood pressure, diabetes. Are they a smoker? Add up the total points. And so you go down the total points. Say, I got 4 points against me, which means that I have a 7% risk of having a heart attack in the next 10 years. So most doctors, even if my LDL cholesterol is a bit high or my blood pressure is creeping up slightly, probably won't do anything. But that's not necessarily the best way of looking at longevity and healthy life expectancy. So that's sort of where there's a divergence in maybe the way we look at things and the way that traditional medical care is undertaken. Because they don't want to write prescription drugs if they don't have to, because they know that drugs can have side effects. So they have to say, I don't want to intervene if I don't have to. But in terms of lifestyle medicine, you can start getting aggressive much sooner. As soon as the LDL is slightly higher, blood pressure is creeping up, or the HDL is a bit too low, you can get much more aggressive to try to get that risk for heart disease as low as possible. And then the other one for men, of course, is rather than using the LDL cholesterol, the second box just looks at total cholesterol. So that one gets substituted for the LDL. So again, it's age, total cholesterol now, it's not LDL, HDL, blood pressure, diabetes, smoking, add up the points and see what the risk is. And then they have the same forms for women based on the LDL. Here's the LDL cholesterol box, and then here's the one for women, the total cholesterol box right here. Otherwise, everything else is the same. So let's leave it there. When we come back after the break, I just want to quickly discuss the key nutrition and lifestyle strategies that you use if you see some of these abnormalities, just to drill them home one last time. We'll cover them pretty quickly. So I'll see you when I